Hi, good evening or good afternoon, wherever you are. From Switzerland, Bern, this is Thomas Suter. I'm more than happy to participate in this meeting. What a great meeting, what a great set we have here. Just one bad thing is that we can't be together at one place, but these are the times we're dealing with right now. But nevertheless, I think it's an excellent meeting, perfect. Thank you, Teresa and the entire team for putting together such a great meeting. And without further ado, I'm happy to introduce the next session, which is Immunotherapy Essentials for Cardio-Oncologists. And our first speaker is Javier de Castro, who is currently an Associate Professor of Clinical Oncology and Palliative Care in La Paz University Hospital in Madrid, and he is going to educate us on the newest progress of the immune checkpoint inhibitors from an oncological point of view. Javier, please take it away.
Thank you very much, Dr. Sutter. So first of all, I would like to thank organizers for inviting me to this interesting meeting. It's my privilege to have the opportunity to share the new advances in cancer immunotherapy in this 2020 year, and perhaps new trends that we can share. This is my disclosure. So, as you know, immunotherapy continues every day increasing and spreading new indications in cancer treatment. In fact, in some tumors, for example, melanoma or lung cancer, immunotherapy is currently the standard of care for most patients. But as you know, the number of new tumors is increasing every day. So, yes. Of course, the first step in immunotherapy treatment in cancer was studied in advanced disease. So the main goal in this situation is to try to improve overall survival of the patients. But it was very interesting to see that prolonged survival was possible in some indication. But now they have the opportunity to reach the chronification in some situation. Let me know some example. For example, 2 weeks ago in a small meeting in European Medical Oncology meeting, was presented this clinical trial, KEYNOTE-24, that is very interesting because it's focused in non-small cell lung cancer in patients with high expression of PD-L1, as the results are impressive because we have around 32% of advanced lung cancer patients still alive 5 years later. That is completely impossible to see before the arrival of the immunotherapy. So we have the possibility to dream that chronification is not a dream. It's something that we can raise. The rationale to combine chemotherapy and immunotherapy at the beginning was very complicated to understand, because sometimes chemotherapy is the opposite. Sometimes the use of chemotherapy is immunosuppressive. But after that, we can see that in some cases, chemotherapy can produce a very interesting immunogenic cell death. So this is the beginning to improve, to try to accelerate the benefit of the immunotherapy. So the next steps are to try to combine immunotherapy and chemotherapy, and this is another clinical trial, very impressive in non-small cell lung cancer, and just relieve final result combination chemo plus immunotherapy. And this is very interesting because if a high expression level of PD-L1 is around 30% in this case, doesn't matter the level of high PD-L1 expression, that you can see here, around 50% of potential advanced non-small cell lung cancer patients can be candidate for this combination. And this is the 3-year final analysis. And after 2 years, we can see that around close to 50% of patients are still alive. So again, the potential benefit is not only to prolong survival, but also the potential benefit in chronification, in try to be completely chronify the disease. And as you know, sometimes at the end of the cure, we can see in all the immunotherapy treatment in the majority of clinical trials, the benefit of the best survivors can be reached a plateau. So after 2 years, if you have more than 40%, we can expect 3 or 4 years later, perhaps more than 40% of or 30% of patients still alive in the global population. So this year we can have also in lung cancer another important approach, that is you can to try to avoid the use of chemotherapy, no 4 cycles, in this case only 2 cycles, especially to try to avoid the early progressors that we can find at the beginning of the cure when you use only immunotherapy. In this case, only two cycles of chemotherapy combining with 2 immuno agents, in this case, was enough to improve a very interesting result. Let me show you some concept that perhaps as cardiologists you have to be familiar with. First is the pan-tumor paradigm. This is sometimes, of course, PD-L1 expression was the first biomarker, but beyond PD-L1, the finding of new biomarkers was very difficult, but TMB, tumor mutational burden, can be very interesting because it doesn't matter the type of the tumor. In this case, it's not studying tumor by tumor. In this case, it's only studying the high level of TMB. So the concept of pan-tumor is very interesting because in different tumors, we can reach interesting responses and also results in prolonged survival. Another important approach is the concept of tumor agnostic. It's very well known when you consider patients harboring which tumors harbor druggable mutations. But in terms of immunotherapy, we don't have druggable mutations. But in this case, we have another important biomarkers such as MSI. MSI was studied, and the first study was demonstrated that in a small group of patients with advanced colorectal cancer harboring MSI, the benefit of immunotherapy was very interesting. And it's very interesting to remember that the immunotherapy only works in this group of patients, of colorectal patients with this biomarker. But after this first study in colorectal cancer, another studies looking for MSI in different pathologies demonstrated the potential benefit of immunotherapy in this situation. So in this case, doesn't matter the histology. In this case, is more important, is more relevant, the MSI, the biomarker. And finally, we have some orphan tumors. This is the example of the cell Merkel tumor. Is a tumor when you don't have, before immunotherapy, we didn't have a very useful treatment because chemotherapy didn't work very well. But in this situation, the immunotherapy was the only and the most important new therapies for these patients with orphan tumors. Of course, the next step was to move on to the early stages. And this early stages is completely different because in this case, we try to reach not only prolonged survival, but we try to avoid the relapse of the disease, the concept of disease-free survival, and of course to try, at the end of the day, to try to improve the cure of the patients through 2 approaches, adjuvant approach and neoadjuvant approach. Adjuvant approach is the one that we consider after surgery to try to eliminate the potential micrometastasis using systemic therapy. Neoadjuvant therapy is a little bit more complicated because sometimes it's used when the tumor can be resectable, but sometimes it's locally advanced. So when we combine multidisciplinary therapies, for example, in this case, chemo plus immunotherapy, the goal is to try to shrink the primary tumor and also to eliminate the potential micrometastasis. So talking about adjuvant therapy, this year in ESMO meeting, this is the result of adjuvant of the clinical trial focused on melanoma, of adjuvant melanoma. This is very interesting because using immunotherapy, patients achieve better survival. So perhaps when you try to avoid the relapses of the patient is the main issue to increase the survival and to increase finally the cure. So if you are able with immunotherapy to avoid distant metastasis and also to achieve the control of the local regional situation, we will be able to do that. Let me know a Spanish lung cancer group. In this case, this is very interesting. This is an trial focusing on a neoadjuvant setting for resectable lung cancer. And this is very impressive because when we combine chemo plus immunotherapy before surgery, we can reach around 78% of radiological responses, and what's more interesting, we can reach major pathological response after surgery, more than 85%. So this is interesting, and this is a new approach, and perhaps with this new approach, we will be able to cure more patients in a very difficult situation. This
two more minutes, huh?
This paper has been published in last Friday. I have the opportunity to participate in this paper also in Lancet Oncology. Let me know one of the patients included in this clinical trial. This is nice because this lady achieved a complete radiological, metabolic, and also pathological response, but unfortunately he suffered in the postoperatory period a COVID disease in a unique lung situation, pneumonia, but luckily the patient recovered after COVID. So it's interesting also. Finally, the main approach is the situation that we consider an early intermediate stages. We don't have a very early stage. We have a locally advanced disease. The majority of patients in these situations can be suffer progression of disease after a partial response of chemo or radiotherapy. So the main issue in this situation is to try to prolong free survival. And if we were able to do that, the next step again was to find a long survivor, and finally, perhaps, why not, a cure improvement. This is result for 4 years follow-up of Pacific clinical trial, again in lung cancer, combining chemoradiotherapy plus durvalumab as maintenance therapy. As you can see, the result of using durvalumab as maintenance therapy is better than using only chemo and radiotherapy. Again, after 4 years, if we are in the situation to consider this difference in terms of survival, perhaps we can talk not only long survivors, perhaps we can talk about more patients that get a cure. So this is my my last slide is to say it's okay. Immunotherapy is nice, but around 30 or 40% of patients are not able to reach a very nice response, or sometimes can be also resistant to immunotherapy. So we have to investigate new approaches in terms of new combinations, new immunoregulators, and also to try to study the potential benefit of immunotherapy depending the immunological situation of the host, of the patient. So we have to continue studying more new combinations. Sometimes it's very interesting to try to combine new options, because to try to repeat the same result combining chemo and immunotherapy, perhaps we are going to have me-too clinical trials where we have to move on to new situations. So to sum
thank
up,
you so much, Dr. De Castro. I think we have to move on, and I give the lead to Dr. Salem in Paris.
Okay, this is the take-home messages that you can see here. Okay, thank you.
Thank you very much, Dr. De Castro. So, Joël Salem from Paris. It's my great pleasure to introduce Dr. Tom Nealon from Boston, who is going to discuss and present us about current detection and treatment strategy for ICIs-induced cardiotoxicity, a theme where he has been working a lot.
Thanks everyone for the kind invitation. Chairpersons, thank you for the introduction. If I could have my slides, please, that would be great. There's a little bit of a delay when you press yes, but these are my disclosures, if I can get that far. The delay is quite long when you're calling in from Boston, I see.
Mm-hmm.
If I can ask some advice, these slides won't advance. Yeah. All done.
Slides, please.
Here we go. These are my conflicts of interest. And I'm going to give a slide on the background because this was so nicely covered by Dr. Castro. It's clear that immunotherapies for cancer are a paradigm shift in cancer care. I'm not going to review in detail about immunotherapy, but I would point you to these excellent recent reviews by members of the panel. So what is the incidence of ICI myocarditis? Well, it's widely debated, with broad figures ranging from 0.06% all the way up to perhaps even over 5%. And you know, some of the issues related to the incidence of ICI myocarditis are related in part to how difficult a diagnosis is of myocarditis in general is to make, as we've seen with the COVID controversy, but also because of the varying definitions. And you know, if a patient who recently started an immune checkpoint inhibitor comes in with any one of these syndromes, you know, they're not all myocarditis, but they're likely related in part to an inflammatory situation related to a recent start of an immune checkpoint inhibitor. So what are detection strategies? Well, these are the detection strategies available for the assessment of cases. And I'm going to go through most of these in a tiny bit of detail. Data are relatively clear that an elevated troponin is a common finding among patients who were presenting with ICI myocarditis. In this small case series, an elevated troponin was noted in over 90% of patients. An elevated NT-proBNP was also noted in over 60% of cases. How about an ECG or an EKG? Well, non-specific STT wave changes are also common in well over 60% or 70% of cases. But also there are quantitative methods that we can derive from the EKG, such as the PR segments, the QRS, and the QTC. And preliminary data suggest that an increase in the QRS duration might be a useful diagnostic approach for assessment of cases. So if you see a patient in the outpatient setting who you've got a concern, I think a reasonable start would be a measurement of troponin and performance of an EKG. And that's very useful if you have a baseline EKG and a baseline troponin to compare those values to. How about ejection fraction? Obviously, standard first-line test is the performance of an echocardiogram and measurement of ejection fraction. The issue here is that the ejection fraction is frequently normal. Indeed, it's far more common to have a normal ejection fraction than to have an abnormal ejection fraction in ICI myocarditis cases, with a normal ejection fraction in over 60% of biopsy-proven cases. The issue as well is that a normal ejection fraction does not preclude the occurrence of a major adverse cardiac event. Indeed, about 40% of major adverse cardiac events occurring after immune checkpoint inhibitors actually occur in those individuals with a normal ejection fraction. And that's a bit of a paradigm shift, because traditionally we've been thought that if you have myocarditis in a general setting, that the presence of a normal ejection fraction is usually puts you in a good place, but not in the case of ICI myocarditis. How about global longitudinal strain? Well, it's been applied widely in the setting of standard cytotoxic chemotherapy drugs. And it indeed also appears useful in the setting of ICI myocarditis, where there is a reduction in global longitudinal strain at presentation with ICI myocarditis compared to baseline. And also of importance among individuals with a preserved ejection fraction, there's also a decrease in global longitudinal strain. In someone presenting with a reduced ejection fraction after starting an ICI, the diagnosis is a little more straightforward. But the complicated group, which are the most common group, are those with a preserved EF. And here it appears that a reduction in global longitudinal strain has value. How about cardiac MRI? Well, the gold standard non-invasive technique for the diagnosis of myocarditis. And indeed, when you do an MRI in these individuals, you can see these pretty pictures. Here is a transmural late gadolinium enhancement. Here's subepicardial. Here is mid-myocardial. Indeed, in the transmural, which is traditionally associated with myocardial infarction, in all these cases, they were biopsied and biopsy-proven myocarditis, so despite the presence of transmural late gadolinium enhancement. And so you can see all these patterns. But when you aggregate the data actually suggests that the absence of late gadolinium enhancement and the absence of edema on black blood imaging do not exclude ICI myocarditis, especially in patients with a preserved ejection fraction, but also in patients with a reduced ejection fraction. I think that point is relatively important. So the absence of late gadolinium enhancement and the absence of T2 of edema and T2 imaging does not preclude ICI myocarditis. Of course, this study was done without the benefit of updated techniques such as T1 and T2 mapping. And how about when you apply those techniques? Well, these are preliminary data, so I should stress that these are preliminary data. But it does appear that an elevated native T1 and an elevated T2 are indeed useful for both the diagnosis of ICI myocarditis and also for prognostication, especially for native T1. The gold standard is endomyocardial biopsy, and that's always our default when diagnostic uncertainty remains even after all these testing. And in the myocardial biopsy, the pathological features on H&E are very similar to those seen in transplant rejection, which is where we derive a lot of our treatment algorithms from. So this is a proposed definition. It's an excellent framework for the approach to the patient with ICI myocarditis. Certain areas are very well established in this framework, including pathology and the diagnostic EMR. Other areas are less well established, so PET-based approaches, which are very interesting and exciting, but probably like most things in ICI myocarditis, need further work. So this is my suggested approach to clinically suspected ICI myocarditis. Our initial tests are straightforward: EKG, troponin, BNP, and echo, including GLS. In a stable patient, they have a cardiac MRI. We apply the modified Lake-Louise criteria, and if they're diagnostic, then you have a diagnosis of ICI myocarditis. If none of the modified Lake-Louise criteria are met, but the suspicion remains very high, then one would have to discuss doing an endomyocardial biopsy, especially if the suspicion remains high. If the patient is unstable, then the diagnostic algorithm is a little more straightforward in that it's cardiac catheterization and endomyocardial biopsy. So should we perform cardiac screening prior to an immune checkpoint inhibitor? The answer from me is 100% yes. Every patient should have a baseline EKG and a troponin prior to starting an immune checkpoint inhibitor. The reason for that is many of these patients can present with vague syndromes. Then somebody raises the concern for ICI myocarditis, and an EKG and a troponin is checked. In many of these patients, they have a detectable troponin and a slightly abnormal EKG, and it's very useful in that setting to have a baseline to compare it. How about on-treatment surveillance? Well, I think on-treatment surveillance is a little more complicated. I think if you can apply this to a high-risk group in a clinical research setting or a clinical study setting, then it's reasonable to ask the question. So there's a couple of ways to identify high-risk groups. A study from Dr. Orn at Mayo Clinic identified these 3 high-risk factors. And this is, and the study on the right is unpublished data with over 6,000 patients treated an immune checkpoint inhibitor, whereby applying machine learning actually identified a group with a 10% risk of serious adverse cardiac events. So I think a way to start might be to do a surveillance within a clinical study among these high-risk populations. I'm going to talk about treatment. And there are 2 options, corticosteroids and beyond corticosteroids. So every guideline says corticosteroids is the first-line treatment option. What they vary on is the dose of corticosteroids, with a lot of the guidelines falling down around 1 to 2 milligrams per kilogram of prednisone. But the guidelines do vary, and the guidelines vary because there's equipoise, because there are no data to be definitive. This was a retrospective study of over 100 individuals, which suggested that high-dose corticosteroids greater than 500 milligram methylprednisone equivalent was actually beneficial in the setting of ICI myocarditis. The other thing that came out from this study was that timing of treatment was very important. So it actually looked like, as well as higher dose corticosteroids, that earlier initiation of corticosteroids was associated with a much lower rate of major adverse cardiac events. And so the point I would take from this is that if you're going to treat with, if you have a high clinical suspicion, you need to start with corticosteroids early. Trouble is we may be winning the battle but losing the war, and I recognize there is controversy in this area about the impact of the dose of corticosteroids on cancer outcomes, with some data suggesting it's okay to give higher dose corticosteroids and some data suggesting it may adversely impact cancer outcomes. The other issue is this corticosteroid resistance, which is a concept raised by Dr. Salem, which is that major adverse cardiac events actually haven't dropped over successive years among patients. You know, we don't have updated data for late 2019, 2020, so maybe it has declined a little bit, but there still remains a relatively high rate of major adverse cardiac events despite the increasing dose of corticosteroids used. So what if you have corticosteroid resistance? Either the patient doesn't respond or has an adverse event. I'm just going to take the example of the NCCN guidelines, which suggest infliximab, CellCept, IVIG, or ATG. I have real concerns over the use of infliximab in this setting. Early data suggests, and some data also led by Dr. Frank Tooney, I think, suggests that infliximab might be associated with an increase in major adverse cardiac events in the setting of ICI myocarditis. So recently, we've steered away from the use of infliximab.
2 more minutes, please.
2 more minutes.
Thank you. So what are the treatment options beyond corticosteroids? There's abatacept and alemtuzumab. These are 2 very exciting publications recently supporting the use of abatacept and alemtuzumab. This is a graphical abatacept story. It's unpublished data from a close colleague of mine, Dr. Mahmood. 58-year-old patient, combination immune checkpoint inhibitor, presented with fatigue and an elevated troponin, otherwise was stable initially, started on methylprednisone 1 gram a day and CellCept 500 milligrams twice a day. Despite starting those therapies, rapidly declined and developed complete heart block and ventricular tachycardia with cardiogenic shock. He got a single dose of abatacept, 10 milligrams per kilogram, with this remarkable response in his serum troponin and a remarkable decline in his requirement for vasoactive agents. So this is suggested management. Ejection fraction normal, no malignant rhythm, a gram of Solu-Medrol for 3 to 5 days. If it persists and the patient is fine, mycophenolate is not an unreasonable option. If it persists after the addition of mycophenolate, then I think these are the options painted on the bottom left here, but more and more we're moving towards drugs like abatacept. If the ejection fraction is reduced and the patient is unstable, I would always ask your advanced heart failure colleagues to come and see the patient, not so much for transplantation, but for consideration for mechanical support, because if you can ride this patient through the acute injury, these patients generally do better. If the biopsy is positive, then high-dose corticosteroids, and if the patient is not responding to high-dose corticosteroids, I would probably add either ATG or abatacept early. So this is my summary. I would say that these are the FDA approvals for a checkpoint inhibitor shown on the left, 2017. On the right is 2019. And if I showed the data from 2020, this individual would probably have increased in size. And we need to work together to figure this out, as the number of indications will increase. This is a slide which shows the number of clinical trials in different cancer areas. And you can see that the phase 1, phase 2, and phase 3 clinical trials, there is a huge number of clinical trials, over 3,000 clinical trials in this area. A lot of these combining them with standard cytotoxics and targeted therapies. Thank you very much for your attention, and I look forward to any questions.
So, Tom, thank you so much. Excellent presentation as usual. Great discussion. And I think we're going to start with a few questions. There have been a few questions here on the chat. I want to quickly start with Dr. De Castro. If you look into the future of ICIs, what would be your prediction? Is it eventually so that we can avoid cytotoxic chemotherapy and completely treat patients, even with metastatic disease, with ICIs?
Yes, I think this is something that we have to sort out, because the role of the chemotherapy continue being very important in different tumors. So I think I'm not sure that we are going to avoid completely chemotherapy in the next future, but perhaps should be very interesting to try to look for shorter chemo cycles, the number, and perhaps the schedule of the chemotherapy. And also should be very interesting to consider the duration of the immunotherapy. Some studies, can be only 2 years. Some studies continues until progression and until side effects. So I think something that we have to try to explore in the next future. But I think chemotherapy will continue to be one of the important part of our treatment, oncological treatment, for several tumors.
And one very quick question. I think with anthracyclines, we saw that if you use anthracyclines neoadjuvantly, it seems to be less cardiotoxic than if you use anthracyclines in the adjuvant setting, although there are many other factors which play into it. How is this with ICIs? Do you see, and I'm not only talking about myocarditis, but toxicity in general, do you see that if you use ICIs in the neoadjuvant setting, less toxicity than in the adjuvant setting?
It should be, but especially because sometimes in adjuvant setting, the number, the cycles, the schedule is shorter than in adjuvant setting. So I think another issue is when you consider adjuvant setting, we are treating patients without cancer. When we consider when you are treating patients in the adjuvant setting, we are treating patients with cancer. So I think it's different, because in adjuvant setting, the avoiding side effects is very, very important, because the patient can suffer a fatal side effect. So I think it's very important to try to avoid this in adjuvant setting.
Thank you so much. Dr. Salem, do you want to take over?
Sorry?
So I'm not quite sure if he still is here. Dr. Salem? So before we lose more time, so let me push on. So then let me ask you a question to Tom here that comes actually from Mexico, from Dr. Garza. And he wants to know, if you don't have MR and if you cannot biopsy the patient, what would be your best tool to assess the risk of a patient regarding myocarditis? Normal echo, troponin, normal BNP, normal ECG. Does that all exclude myocarditis?
I think you've probably likely done if you have a normal ECG, normal troponin, normal NT-proBNP, and a normal echo, including global longitudinal strain, I think you've done a pretty reasonable job. I understand it's not impossible to get to have myocarditis even with a normal troponin, and it's not impossible to have myocarditis obviously with a normal ejection fraction. But it's a little unusual to have myocarditis without a change in serum troponin. So I think you've done a pretty reasonable job at that stage.
Okay. So another question is, if you have a strong suspicion of ICI myocarditis in the MR, and the MR is inconclusive, would you move on to get a PET CT scan in this patient?
Thank you for the question. Data are evolving about the application of PET in this setting. It's very exciting. I think that if you have an indeterminate cardiac MRI, then the next best step right now is an endomyocardial biopsy. I think until we see a little bit more published data about the use of PET scanning in this setting, it's tough to comment exactly. I mean, it's certain PET tracers are very interesting to me, including granzyme B. But we don't have a lot of published data, so I think we have to wait for that.
Okay. So the next question is...
Sorry, I had a connection issue.
Okay, go ahead.
So within the questions that have been asked from the people is, what do you think about troponin monitoring, how often you will do it, and what do you think is the incidence of asymptomatic troponin increase, and is a troponin increase always suggestive of ICI myocarditis? So all this.
What a great set of questions. And so clearly a troponin increase is not always ICI myocarditis. I think that usually we do the standard stuff, which is whereby we look for whether it could be coronary disease, it could be sepsis, it could be some other hemodynamic insult. I think it's entirely possible to have I think it's just a little unusual for somebody, you have a baseline value of troponin and you have a follow-up troponin, and they're both exactly the same number. For me, it's a little unusual and a little unlikely that they have myocarditis. Now, do we routinely do surveillance here, which is on-treatment surveillance? We do not. And until I think that there's a nice clinical study which shows that surveillance provides value, then it's tough, because I think most of the elevations in troponin in that setting might actually be not myocarditis. And I wouldn't want to go down the route of the HER2 story, which is where these life-saving medicines were stopped for an asymptomatic reduction in ejection fraction, when in reality work has suggested from Dr. Anna Barak and Dr. Dara Leon that maybe we don't need to do that. So I think for surveillance, we probably need a nicely structured clinical study to tell us there's value in surveillance and identify different cutoffs for changes in these biomarkers. I don't routinely do it here, but for baseline assessment, I would strongly recommend that every patient have an EKG and a troponin. It just puts the change in these variables in comparison when there is a clinical concern.
So another question would be, what is risk factors to develop ICI myocarditis when you're on immunotherapy? Would you have some recommendation for the people to eventually be followed up more?
Yes, great question. So age is a risk factor. Combination immune therapy is a risk factor. I think if a patient is presenting with other syndromes, such as specifically myositis, that is clearly a high-risk patient. So age, combination immune therapy, someone who presents with a syndrome, which is with a myositis syndrome, because their risk is higher. I think then there are evolving data that some other early risk factors, which include pre-existing cardiovascular disease, especially heart failure, is probably a risk factor. Beyond those, there's some lovely work from Dr. Mushlehi about being female may be a risk factor for ICI myocarditis, especially in his animal models. So far, those would seem like the risk factors that that have been identified, and perhaps diabetes as well.
Super, Tom. Thank you so much again. I think it was an excellent session, hot topic. We were flooded with questions, and I'm afraid we couldn't cover tenths of it. And I'm sure next time when we're going to see each other face to face at wherever this is going to be, these people come up to you to the stage and ask you the question. So thanks again. But unfortunately, we have to close the session. Thanks again.
Thank you very much. Thank you.
Thank you.